So the testicular surgery and the conditions of the testes is also a very much important and the common topic to be discussed, because there are a number of the conditions of the testes which are very common, and we deal with them in our day-to-day surgical problems. Besides that, this is also an important field in the urological surgery as well. So a urologist should always know the different kind of these testicular surgeries and the testicular conditions. We will be discussing the surgical problems encountered in case of this entity one by one. But before that, you should know a little bit about the anatomy and also a little bit about the function and the blood and the lymphatic drainage of the testes. So if we particularly talk about the testes, they're important male sexual organs which are located in the scrotum in the perineal region. So if we could appreciate in the diagram that there are different kind of the structures like this spermatic cord. This is a kind of the cord which is located in the inguinal canal, and through this spermatic cord the testes are actually connected to the abdominal wall and the contents of the abdomen as well. You can see here that they're kind of the seminiferous tubules, and they are ultimately leading into the epididymis, and then epididymis is going upward, and this is the vas which is located in the spermatic cord. You can see here these are the straight tubules of the testes, and they're the rete testes, and obviously the straight tubules are entering into the seminiferous tubules, and they are then you can also see the different kind of the septas, which are the tunica, kind of the layer of the tunica albuginea, which is dividing the testes into different septas, and this layer of the tunica albuginea is actually the fold of the peritoneum, and it is developing from the processes vaginalis. We'll be discussing a little bit about the embryological development of the testes, and you can see here this is the tunica albuginea, and they're entering into the testes. This is the tail of the epididymis, this is the head of the epididymis, and they're entering into the vas deferens. Now the most important thing you guys should know is like the testes are developed into they are actually in that's kind of the retroperitoneal structure which is located in the abdomen. By the age of the 3 months, or you can say by the third gestational period, gestational age, the testes are located in the abdomen. But with the passage of time, as the gestation age is increased and near about 7 to 9 months, they follow the track of the spermatic cord, and that spermatic cord they are actually going down into the spermatic cord. Now you should always know a little bit about the anatomy of the deep inguinal ring, the superficial inguinal ring, and we know that the spermatic cord is actually which is located in the inguinal canal, starting from the deep inguinal ring or the internal inguinal ring, coming down to the external or the superficial inguinal ring. Now, there are a few things which are very much important as the gubernaculum, and gubernaculum is, you can say, a precursor of the testes, and it's actually in the 3 months of the gestational age, what happens is like the gubernaculum is formed within the layers of the peritoneum, and the different kind of the folds of the peritoneum which form the gubernaculum, and it then goes down from the abdomen into the inguinal canal. Now, this is the route which is being followed, and almost nearly at birth, the testes are in the scrotum. But sometimes it happens that the testes do not migrate or do not descend from the abdominal cavity into the scrotum. Why? You should also know this thing, that why the testes should be in the scrotum, because it's a kind of the temperature difference. So they need a kind of the cooler environment, and it's almost 1 degree Celsius lesser temperature in the scrotum, and for that the testes, for the process of the spermiogenesis, the testes should be in a cooler environment. That's the reason the temperature in the scrotum is less as compared to the rest of the body. That's the reason there is a descent of these testes from the abdominal cavity into the scrotum region. So you can find out the testes either in the inguinal canal, or there can be 4 different positions. They can be the testes can be into the abdominal cavity, which is the extraperitoneum. The testes can be in they are extracanalicular, they're intracanalicular, or they are just close to the epididymis, right? So if you talk about the blood supply and the lymphatic drainage of the testes, you should know that there are 2 kinds: the testicular artery, which is the branch of the abdominal aorta, and they arise just below the renal arteries, and they then come and supply the testicles. And if we particularly talk about the lymphatic drainage of the testes, these testes are actually draining into the testicular veins, right and the left testicular vein. The important thing to know is the right testicular vein is directly draining into the inferior vena cava, and the left testicular vein is first draining into the left renal vein, and then it is draining into the left renal vein. It's ultimately draining into the inferior vena cava. So basically, the right testes is following a shorter pathway because it's directly draining into the inferior vena cava. And if we compare it with the left testes, then the left side is draining first into the left renal vein, and then ultimately draining into the inferior vena cava. So, and if we talk about the lymphatic drainage, the testes are actually directly draining into the para-aortic lymph nodes, as the testicular artery is a direct branch of the abdominal aorta just below the origin of the renal arteries. The important condition in case of the testicles is like the incompletely descended testes or undescended testes. And other conditions can be testicular torsion and different kinds of the injuries to the testes. So what we're going to do is we're going to discuss these in detail. Why you should embryologically, you should know the concept behind the incompleted descended testes, right? So actually, what's the pathology behind the incompleted descended testes is actually testes are developed into the abdomen. And then for the survival and the process of the spermiogenesis, they pass through the inguinal canal through the spermatic cord, and then they are actually laying in the scrotum. So in case of the incompletely descended testes, like the testes can be intra-abdominal, like the extraperitoneal, intracanalicular, extracanalicular, which are usually at the scrotal neck, and then there can be ectopic testes, which are usually in the superficial inguinal pouch. The thing which is very much important is little bit of anatomy of the inguinal canal should be very much clear to you. There are 2 kinds of the rings which are present in the inguinal canal. Like inguinal canal is starting from this deep inguinal ring coming to the superficial inguinal ring. So the deep inguinal ring is actually the midway of the inguinal ligament. That is the landmark for this is anterior superior iliac spine and the pubic tubercle. The midpoint of the inguinal ligament is actually the part of the deep inguinal ring, and the superficial inguinal ring is just medial, and it's medial to the inferior epigastric vessels, and the deep inguinal ring is lateral to the inferior epigastric vessels. So the pathway testes can be found along any one of this pathway. Like they can be intra-abdominal, and usually they're retroperitoneal, but intra-abdominally they can be extraperitoneal, they can be intracanalicular, they can be extracanalicular at the scrotal neck, or they can be ectopic testes, which are located at the superficial inguinal ring. The thing which is very much important is sometimes there's a hernia as well, along with the undescended testes, and then you have to reduce the hernia, you have to lengthen the cord, and then you have to bring down the testes into the scrotum. So if we particularly talk about the pathology, actually they can be intra-abdominal, extracanalicular, they can be ectopic testes, and sometimes the pathway is arrested, and the testes can be arrested in anywhere in the pathway coming from the abdominal cavity into the scrotum. And because of that, when the testes are not in the scrotal region, the process of the spermiogenesis is affected, and there would be loss of the lytic cells, there would be loss of the Sertoli cells, there would be degeneration, and ultimately they're going to lead to the infertility. So these incompleted descended testes, or the undescended testes, they have some kind of the consequences which are very much grievous, especially the chances of the malignancy. So we particularly talk about the consequences. The first important consequence is the infertility. Why infertility? Because I already told you the process of the spermiogenesis, they need the actually a cooler environment which is present in the scrotum for the process of the spermiogenesis. But either the testes are in the inguinal canal, or the testes are in the abdominal cavity. Because there is increase of the temperature, so because of that, the process of the spermiogenesis is badly affected, and that lead to the infertility. The second most important consequence and a great concern is about the malignancy, and the percentage of the undescended testes developing into malignancy is like 15 to 20%, right? So that's why it's very much important, especially the infertility is common in the young boys, and the malignancy is more common in the young adults and the and adolescent age as well. In that case, there's another consequence, which is the hernia, because if there is the patent processes vaginalis, so particularly, the testes are actually in communication with abdominal cavity. So most of the time, along with the undescended testes, there can be inguinal hernia coming through the deep inguinal ring, and most of the time the hernial sac, it usually do not contain any intestine, but it may contain the intestine, because they're connected to the abdominal cavity as well. And obviously there can be a risk for the testicular torsion as well. Why the testicular torsion? Because the length of the epididymis is affected in case of the undescended testes, and because of that, the testes can actually twist around themselves, and they can lead to the testicular torsion, which is extremely painful condition. So that's why the surgery for the undescended testes, it should be in the earlier age, like before the 2 years, so to decrease the risk for the infertility and to decrease the risk for the malignancy as well. So if a patient is coming to you, or the child is brought to you by his parents, would be the clinical features or would be the present complaints. So you should always think in mind that the patient will tell you particularly that there may be left or the right testis is present, but the other testis is absent. So sometimes, it can be a retractile testes. There's a different entity as compared to the undescended testes. In case of the retractile testes, the cremasteric reflex is very much sensitive. So whenever you touch the scrotal skins, the testes, they in response to the cremasteric muscles, they are retracted in the inguinal canal, and when that reflex is ended, they come back again to the normal position that is in the testes. So because in case of the retractile testes, there's no specific treatment, and the patient should not undergo any surgical procedure because that's a reflex movement or the reflected ascent of the testes into the inguinal canal or abdominal cavity, and when the reflex is gone, they usually come back to their normal position. So it's important to ask in the history that do the testes ever come back in the scrotum or not. The patient will tell you that whenever we stroke the scrotal surface, they go into that, they're retracted, and then when the reflex is gone after some time, they come back again to their normal position. So that's important. So you have to differentiate between the retractile testes and the true undescended testes. So this is something very important you should ask in the history as well. And so, and you should always keep in mind that if a normal boy is presenting to you with the absent testes in the scrotum, then you should always think about the testicular agenesis as well, because sometimes in case of the testicular agenesis, the testes are usually present in the developmental age, but after the birth, they go agenesis. Why they go agenesis? Because sometimes they're in the cavity, there's a torsion, and because of the torsion, the vasculature of the testes is affected and the blood supply is affected. So whenever there is blood supply, whenever blood supply is affected, the testes will ultimately become dead. So agenesis of the testes should be in your mind as well. Retractile testes should be in your mind, and you always need to examine the scrotum of the patient, because in case of the retractile testes, the scrotum is always and always normal. Okay, so if you have made a diagnosis of the undescended testes and you have differentiated it from differentiated the undescended testes from the retractile testes, or you have differentiated it from the true agenesis of the testes, then there are some kind of the procedures which are available for the undescended testes. Usually the undescended testes are along with the hernia as well, which is most commonly the indirect inguinal hernia. So what you do is you do Orchidopexy, and you also do the herniatomy if the patient is complaining of the hernia as well. What you do, Orchidopexy, that's a kind of the two-stage procedure, and you give the two incisions. One incision is given in the groin, and you approach the inguinal canal, and the other is in the scrotum, a small transverse incision in the scrotum. And then what you do is you actually, first of all, you lengthen the cord, you separate the testes from the spermatic cord, you bring them out, there are 4 different structures which are located in the spermatic cord. The one is the vas deferens, the other is a testicular complex, and the pampaniform plexus. So what you do is actually, and they're kind of nerves as well, which is a genital branch of the genitofemoral nerve. So what you do is actually, you need to separate the contents of the spermatic cord from the hernia and the testes in the inguinal canal. So what you do is actually you give the incision in the groin, just kind of the incision we give in the treatment of the hernia. You do the herniatomy, you reduce the sac, you push the sac through the deep inguinal ring into the peritoneal cavity, and then you separate the testes and you give an other incision over the skin of the scrotum, and you actually bring down the testes into the scrotum, and then you fix it, right, by the 3 sutures, and you actually fix the testes to the fascia in the scrotum, right? You make a pouch, and then you fix that particular testes so that they do not go back into the abdominal cavity. So you can see in the diagram, this was a little bit overview of the Orchidopexy. You're here, you're approaching that, you're given an inguinal incision here, and then this is basically you have given a separate incision in the inguinal canal, and you're giving the incision in the scrotum as well. You actually mobilize the testes, and you separate the testes from the spermatic cord, you separate the testes from the hernia, and you give another incision in the scrotal area, and you give a transverse incision, and you bring down the testes inside, and you do actually what you do is you do a lengthening procedure. You lengthen the gubernaculum, and you bring down the testes into the scrotum, doing the herniatomy as well if the hernia is present, pushing back the sac, the contents into the abdominal cavity, and ligating and dividing and removing the sac, and separating and dividing the contents of the spermatic cord. So this is the Orchidopexy, which is usually performed in case of the UDT, and if there's there is associated hernia as well, that's also treated by the herniatomy. So this is how you do it. Actually, this is the inguinal incision you do in the groin region. You separate the testes from the rest of the structures. You give another kind of the incision, and then you close the incision, both incisions, and you bring down these testes into the scrotum. And the most important thing in this procedure is to fix the testes in the scrotum with the scrotal fascia, right? And you have to you have to secure that not with the 2 sutures, but actually the 3 sutures, and you have to fix the testes with this fascia. You have to stitch it at least in 3 plans, not in 2 plans. So actually, this Orchidopexy is important, and it is a kind of the 2-stage procedure. So in the first stage, you only mobilize the testes. If there's no hernia, and you're just performing the Orchidopexy for the undescended testes, so actually you do a 2-stage procedure. In the first stage, what you're going to do is you're going to separate the testes from the spermatic cord, you mobilize, and then you just close the incision, and you leave as it is for the 6 months. And after 6 months, you do the second stage procedure, in which the testes are being mobilized, and they're being secured, or they're being fixed in the scrotum with a 3-plane dissection. And you do the dissection in a fascial plane, and actually with that fascia of the scrotum, you fix the testes. So you all have to remember this 2-stage procedures. Okay, so if if you cannot bring down and you cannot mobilize the undescended testes in a 1-stage procedure, you mobilize the testes, you anchor it with a suture, and you leave it for 6 months. And after 6 months, you do a 2nd-stage procedure, right? So see, if there's a failure to bring down the testes, they're mobilized, they're anchored with the sutures, and then also you leave it for the 6 months, and then you do the 2nd-stage procedure in 6 months. Other alternative for this Orchidopexy is like you initially divide the gonadal arteries. When you divide the gonadal arteries, actually you are helping the testes to be mobilized, right? So after the division of the gonadal arteries, you left it, you wait, and then you do a 2nd-stage procedure, which involves a conventional Orchidopexy, giving 2 incisions, 1 incision in the inguinal region over the groin, and the other is in the scrotal region, and bringing down the testes, separating the contents and from the spermatic cord, and bringing down into the scrotum, and then fixing it in 3 planes. Okay, so that was about the undescended testes, and it is very much common, and it's always, not always, but sometimes, most of the times, it is related to the hernia. So you should do orchidopexy with herniatomy as well. So there's an important entity, which is the injuries to the testes, which is very much common. Now, like someone, this sports injury, they can be, or there can be injury to testes while horse riding, right? So, or maybe there can be animal hit or something striking the testes. So, in case of the injuries to the testes, they can be, first of all, there can be collection in the testes, or there can be collection in the scrotum, which is the hematocele. And what you have to do is you have to differentiate the testicular rupture with a scrotal injury, right? Patient will give you the history of trauma, or the history of injury, or the history of fall, and then you have to examine, obviously. And whenever you're examining the patient, you have to see like if there's a kind of a redness, there's a kind of swelling, and how painful is the scrotum, or how tender is the scrotum to touch. Because injuries to the testes are usually, they are kind of similar to their presentation is kind of similar to the epididymal orchitis. So you have to differentiate. Because sometimes these injuries of the testes, they can also be along the epididymal orchitis, right? So what you need to do is actually you have to look for ultrasonography, immediate ultrasonography is very much important. Why this is very much important? Because ultrasound is a gold standard, and it is very sensitive and is very specific to see actually where the hematocele is or where the hematoma is. If there's a testicular rupture, urgent surgical exploration is recommended, right? Because if there's a testicular rupture, obviously that will lead to the infertility. So, it's very, very much important to go for the surgical exploration. And if there's a scrotal injury and there is a kind of the swelling and the tenderness, there's a tenderness over that region, and in ultrasound you see a hematocele or a scrotal hematoma. And if you have identified and you're sure about the testicular rupture or testicular injury, then you can just go for the aspiration of the scrotal hematoma, which is also very, very much important. And also there can be a hematoma in the scrotal wall, and only thing you need to aspirate the hematoma. But always keep in mind that scrotal injury is a surgical emergency, and it is recommended that within 6 hours of the presentation, you should actually you should go for the surgical exploration. You should go for the testicular rupture, because it can later lead to the infertility. So this is something very important. And when you're sure about that it's a hematocele or the scrotal hematoma, wall hematoma, you should always go for the hematoma aspiration, right? Because sometimes in the later stages, actually the scrotal hematoma organizes itself, and it is kind of it's not that much fluid and consistency, and you have to go for the surgical exploration. So there's another entity, which is the absent testes, and I have already discussed in the previous one of the previous slides that actually what happens, the testes are developed, right? They're developed in the abdominal cavity, but because of the torsion, the blood supply of the testes is being compromised, and we know that whenever the blood supply of the testes is compromised, there would be necrosis of the testes, and ultimately they will be dead. So you have to sometimes the patient will complain, the mother will say that my baby has got one testes in the scrotum but other is absent. So obviously the first common thing that will come in your mind is about the undescended testes, but do not forget about the absent testes, because sometimes they're not undescended, the testes are even not present, right? So the causative agent behind this is the deficiency or the incomplete blood supply of the testes, or the torsion of the testes, making the testicular cells dead. Another thing which is very much important is like the emergency surgery for the injuries to the testes. You should always go for the surgical exploration. And in case of the absent testes, what would be the clinical features? Mostly, it's the prenatal torsion. I have already discussed that there is a torsion, and because of the prenatal torsion, that can lead to the compromised blood supply, and because of that the testicular tissue is dead. But sometimes there is a true agenesis of the testes. They're not developed at all. So in case of the agenesis, false agenesis of the testes, actually testes develop, and because of the compromised blood supply they're dead by the childbirth. But sometimes there is a true agenesis and testes do not develop at all. So but that's a very rare condition, very rare condition. And in case of the this agenesis of the testes, what you're going to do is you should perform the laparoscopy, and by laparoscopically you should distinguish the agenesis from the intra-abdominal maltescence, because sometimes they are located intra-abdominally and you do not find them in the tract. And if you try to slide and push the spermatic cord and try to bring the testes from the deep inguinal ring or the inguinal canal into the scrotum, it's not. Sometimes you cannot find the testes in the inguinal canal. So what you do is you should always adopt the laparoscopic approach to distinguish intra-abdominal maltescent from the absent or agenetic testes, right? And the important thing is the torsion of the testes, which is also the surgical emergency, and the viability time for the testes is 6 hours. So you should always go for the urgent surgical exploration. The cause behind the torsion of the testes is, like you can see here in the diagram, that this is the epididymis, and it's the tail of the epididymis and the head of the epididymis. So it is the normal attachment of the epididymis to the testes is like this. And if you consider this, the abnormal attachment, which is the bell clapper, it's a kind of the bell clapper appearance of the testes which are being attached. So because of this abnormal attachment, the testes twist around itself, or the cord of the epididymis. So because of that torsion, the testicular artery is compressed, and because the main supply of the testes is through the testicular artery, which is coming from the abdominal aorta. So whenever that testicular artery is compressed, in case of the bell clapper abnormal attachment, so because of that, the testes undergo necrosis and they become dead. So the viability time is 6 hours, and if you do not do the urgent surgical exploration and you untwist the testes, and once again you decompress the testicular artery and the blood supply is being made available to the testes, they will be dead, and that will lead to the infertility. So that is the reason the torsion of the testes is a surgical emergency. And in case of these torsion of the testes, they're kind of the specific clinical features, and one of the most important clinical feature is the testicular pain. And this pain is the unproportional and a kind of the very severe pain in the groin and the lower abdomen as well. The other important clinical feature in the case of the torsion of the testes, the patient would be apyrexic. That means that the patient would not be afebrile. The patient would be afebrile because the torsion and the epididymoorchitis, both are painful and both present with the scrotal swelling. So if there is a pyrexia or the patient is febrile, you'll think about the epididymoorchitis. And if there is no fever or the patient is prexalt, you will particularly think about the torsion of the testes. And in case of the torsion of the testes, chemostatic reflex is also lost, and the patient may feel nauseated, and the patient can patient can be nauseated and he can vomit as well. And if we particularly talk about the clinical features of the presentation, the patient will tell you that I've got a swelling in the testes and the scrotum, which is extremely painful, and whenever you touch them, they're extremely tender. So keep in mind the clinical features for the torsion of the testes is the unproportionate or the disproportionate pain in the scrotal region, loin and groin and the lower abdomen, and the patient will be aparexic. If patient is febrile, you think about the epididymoorchitis. Chemostatic effect should be lost, and the patient will be nauseated and vomiting. But in case of the clinical examination, how are you going to differentiate a testicular torsion from the epididymoorchitis, right? Whenever you lift the scrotum, the pain of the epididymoorchitis would be relieved, but the testicular pain will aggravate in case of the torsion of the testes. So this is a single important diagnostic clinical sign you have to perform in case of the testicular swelling to differentiate the torsion from the epididymoorchitis. Because if there's epididymoorchitis and you lift the scrotal, then the pain would be settled. But in case of the torsion, the pain would obviously aggravate. So you can see in the diagram, the differential diagnosis for the torsion of the testes would be epididymoorchitis. There can be idiopathic scrotal edema, or there can be mumps orchitis as well. Like, that mumps is a kind of a viral disease, and that can lead to the parotid gland enlargement along with the orchitis. So the differential diagnosis coming into your mind about the testicular scrotal swelling would be epididymoorchitis, idiopathic scrotal edema, or the mumps orchitis. And you can also think about the hernia. So because sometimes the indirect inguinal hernia that comes into the scrotum and that presents the inguinal scrotal swelling. So you should always perform some kind of the important clinical examination, whether you can get above the swelling or not. If you can get above the swelling, you will particularly think about the torsion, epididymoorchitis, kind of the hydrocele or the varicocele. And if you cannot get above the swelling, particularly, you will think about the hernia, the indirect inguinal hernia. So the management for the torsion of the testes is immediate surgical exploration, untwisting, and then fixing the testes. And this fixation of the testes is in the scrotal pouch, and you do the dissection in a facial plane, and you fix the testes with the three non-absorbable sutures with the dartus fascia, right? So this is something very much important. Plus, if the viability time is gone, and if the patient is presenting to you late and the testes have already been dead and necrosed, you should go for the orchidectomy, and you should counsel the patient that your testes are no more viable. So the only option we have available with us is the orchidectomy, and you should counsel the patient about that. And always remember that infarcted testes should be removed, because there's no point of keeping the infarcted testes in that, because that can precipitate and that can lead to epididymoorchitis as well. So for the torsion of the testes, this is the surgical emergency, and you should do the surgical exploration within 6 hours, because this is the viability time for the testes. And if the testes have already developed necrosis and they're dead and they're infarctate, and you should go for the orchidectomy, right? And there's another important entity, which is the varicocele. And we know that actually these are the testicular veins. Left and the right testicular veins, they combine, their branches combine, and they form a pampaniform plexus, which is an important part of the spermatic cord. So you can see in the diagram that this is the normal testes, this is the testes, the epididymis, and this is the pampaniform plexus, which is located in the spermatic cord. And whenever these veins are dilated, they are called as a varicocele. And this dilatation is because of the absence of the valves, or within the veins, or the incompetence of the valves. So actually, they become dilated, they become tortuous, and they're called as the varicocele, right? And if we talk about the etiological factors, you should know that it's almost very common in the adult male, like 15 and 20%, and most of them are left-sided, because we know that the left-sided vein, the testicular vein drain into the left renal vein, and it kind of takes a longer pathway as compared to the right testes. So they're most commonly on the left-sided, and if we particularly talk about the causes, so in case of the young patients, you'll think about the incompetent valves or the absent valves within the pampiniform plexus. And in case of the adults, you'll think about the obstruction of the testicular vein, like the kind of the tumor or nephrectomy, which is compressing that. And our most common usual cause is absence or incompetence of the valves in the proximal testicular vein. So think about these things, that in the young patients, you'll think about like teenagers, you'll think about absent valves or the incompetent valves. And in case of the adults, you'll think about testicular obstruction, which is being caused by the tumor, renal tumor or nephrectomy. So the clinical features with a varicocele would be just presentation like the left inguinal hernia, and there would be positive cough impulse. You'll ask the patient to cough, and the swelling will be more prominent. That is called as a cough impulse. And sometimes with a varicocele, there's a degree of atrophy as well. And when you do the ultrasonography, you can see the dilated tortuous veins in the ultrasonography. And this is something very important. Ultrasound is very much important in case of the scrotal swelling. Why? Because you need to differentiate between the free fluid, the dilated tortuous veins, or you need to differentiate it from the inguinal hernia containing the omentum and the mesentery or the gut loops. So this is something very, very important. If a patient is coming to you with the inguinal scrotal swelling, you take a detailed history, and then you do the examination. And in examination, what you do is you perform three important things. First of all, you will start from the inspection. Look the testicular swelling. It's inflamed, it's red, it's hard, it's tender. If it's tender, it's hard, and it's inflamed, you will think about the epididymal orchitis or the torsion of the testes or injury to the testes, right? And in case of the epididymal orchitis and torsion, you have to lift the scrotum. And when you lift the scrotum, if the pain is relieved, you'll think about epididymal orchitis. And if the pain is aggravated, you'll think about the testicular torsion. But in case of varicocele, you can get above the swelling. If you can't get above the swelling, you will think about the inguinal hernia, and then you go for the ultrasonography, which will differentiate between a varicocele, dilated tortuous pampiniform plexus, or it will differentiate it from the free fluid, like kind of the hydrocele, and then you have to differentiate the mesentery, omentum, or the gut loops. So ultrasonography is something very, very important. Another important thing we need to discuss here is about the process of the spermatogenesis. Sometimes we do not actually know the reason behind the spermatogenesis, varicocele affecting the spermatogenesis, but evidence, there were kind of the evidence that if there's a varicocele present in the adult, that can affect a kind of the process of the spermatogenesis, and the patient will present to you with the oligospermia. And if you do the varicocelectomy, the chances of the oligospermia is not significantly reduced, but the cause behind this is unknown. But usually it's known that varicocele is actually interfering somewhere between the process of the spermiogenesis. So for the treatment options available for the varicocele is the percutaneous embolization of the gonadal veins, or you go and do the superficial ligation of the testicular vein. That because of that ligation, the dilatation would be overcome. There's another important category in case of the inguinal scrotal swelling, which is a hydrocele. And there are 4 different kinds of the hydrocele. That can be vaginal hydrocele, infantile hydrocele, congenital hydrocele, or the encysted hydrocele of the cord. So basically, these 4 things are very much important. In case of the vaginal hydrocele, the causative factor is a patent process of vaginalis. In case of the infantile, the causes again the patent process vaginalis. There can be congenital hydrocele, or there can be encysted hydrocele of the cord. So if we particularly talk about the formation of the hydrocele, because of that we know that the process of vaginalis is kind of the layer of the peritoneum, which is present in the early gestational age. Whenever the baby is born, it converts into the tunica, albuginea, and that's encircling the spermatic cord and the testes as well. But actually, in the process of vaginalis is obliterated. But if the process of vaginalis is not obliterated and the testes are in communication with the abdominal cavity, the fluid from the abdominal cavity that comes into the scrotum, and that's called as the hydrocele. So the causative factors for the hydrocele would be communication with the abdominal cavity, and from that cavity the fluid is coming into the scrotum, or there can be excessive production of the fluid within the scrotal sac, or there can be defective absorption of the fluid, which is called the vaginal hydrocele, or there can be blockage to the lymphatic drainage of the scrotum. So these 4 important things should be in your mind. Like, one is the patent process of vaginalis, in which there's communication with abdominal cavity, especially the cause of the hydrocele in the children. And most of the time, the baby will present to you with the scrotal swelling, and by the age of the 2 years, it closes spontaneously on its own if you have differentiated from the hernia. But if this hydrocele, which is the congenital hydrocele, right? And if this hydrocele is not reduced on its own spontaneously by the age of the 2 years, then you go for the surgical procedure. Or there can be excess production of the fluid within the sac, there can be decreased absorption, or there can be blockage to the lymphatic systems of the scrotum. The secondarily causes for the hydrocele, which is called as secondary hydrocele, and it can be associated with the epididymoorchitis, or it can be associated with the testicular tumors, or there can be torsion of the testes. So one was the primary hydrocele, which is due to the patent process of vaginalis, increased fluid secretion, decreased fluid absorption, or there can be like kind of the lymphatic obstruction, and there can be secondary hydrocele owing to the epididymoorchitis, like different kind of the testicular tumors, or torsion of the testes. So the clinical features of the important, like the inguinal scrotal swelling for the hydrocele, is you have to examine the patient. The swelling will enclose the testes and epididymis, and it would be a red in color. There would be redness, and you have to perform the transillumination test. And in case of the hydrocele, the transillumination test is always positive, right? So you do 3 important things. Examine the swelling. Number 2, you can get above the swelling or not, or you perform the cuff impulse, which is positive in case of the varicocele, and in case of the inguinal hernia, right? The cuff impulse is positive. And in case of the hydrocele, the transillumination test is positive, and there can be associated testicular tumor. Then you have to look up for the signs of the testicular tumors as well. So regarding the clinical features of the hydrocele, if there is a encysted hydrocele or a congenital hydrocele. So in case of the encysted hydrocele, the swelling would be oval, and it would be above the testes, and you can get above, and the swelling move downward and that becomes less mobile. And in case of the congenital hydrocele, that is a patent process of vaginalis, which is called the PPV. So hydrocele fluid that can be drained into the peritoneal cavity. And for the congenital hydrocele, the swelling is usually bilateral, and you have to check for the ascites as well. So these are kind of the features which are associated with a hydrocele. So they're kind of usually you wait for the 2 years, and up to 2 years, the hydrocele, if it's a congenital and patent process of vaginalis, it goes on itself because that layer of the peritoneum goes away. But in case if this hydrocele is not reduced on its own, you go for some kind of the surgical procedure, which is the plication, the Lod's operation, right? So in case of the Lod's operation, what you do is you actually, you divide the sac and you plicate it, like the cavity is basically plicated, and it's divided and it's removed. The other procedure, which is very much common, is Jabolis procedure, and which is kind of the eversion. Like you give a kind of the incision. If it's a small hydrocele, you can just aspirate it, and if you think that it's a kind of the patent process of vaginalis, then you have to go for the eversion or the Jabolis procedure. So in case of the Jabolis procedure, you do the marsupialization, and you actually, you take the stitch from the internal edges, and you continue ligating it in a continuous fashion, and you just evert the sac. The sac is basically everted so that the communication should be separated from the abdominal cavity. Or the other thing is you can go for the excision as well. So the treatment options for the congenital hydrocele is herniatomy, because most of the time these congenital hydrocele are, they are related with inguinal hernia because, and obviously the patent process of vaginalis. So in case of the congenital hydroceles, you go for the simple herniatomy. There's another entity which is called as Filarial hydroceles and the chylocoeles. This is there's a kind of the infection with the organism responsible is a Escherichia bankrofti, and this is also called as filarial elephantiasis, and because whenever recurrent attacks of the epididymoorchitis takes place, and the causative organism behind this is Escherichia bankrofti, and because the fluid is very much, a great proportion of the cholesterol. So that's why they're called as a chylocoeles as well. So in case of the filarial hydroceles, you have to treat the infection. And, sometimes when there's a rupture of the lymphatic channels, this fatty or the cholesterol deposition infiltration takes place, and that leads to the formation of the chylocoeles. So in case of the filarial hydroceles or filarial elephantiasis with the chylocoele, the treatment modality for this is rest, aspiration, and obviously at the end the excision. So this was about the filarial hydroceles and chylocoele as well. So that was all for today's topic. We have been discussing so far about the different kind of the testicular conditions, like the epididymoorchitis, the testicular torsion, injuries, undescended testes, varicocele, and the hydrocele. I think this lecture would be quite beneficial for us, for you guys as well. So thank you for watching sqadia.com. Keep watching sqadia.com.